Let's talk about cephalosporins. They're the absolute workhorses of modern medicine. People always compare them to penicillins, but they're actually structurally superior. And today, we're going to see exactly why. This is your definitive masterclass. Our goal here is to make you an expert. We're going to cover their unique chemistry, march right through all 5 generations with mnemonics you'll actually remember, and we'll spotlight those high-yield coverage gaps and side effects that are practically guaranteed to pop up on your board exams and in your clinical practice. So here's our game plan. We'll start with the structure, get into the mechanism, conquer all 5 generations, learn their big weaknesses, cover the must-know safety pearls, and then wrap it all up with the ultimate cheat sheet. Okay, let's get into it. So, first things first, what really makes a cephalosporin a cephalosporin? It all comes down to its core chemical blueprint and one really key advantage. The big difference between them and their cousins, the penicillins, is right in the core structure. See, cephalosporins are built on a 7-amino cephalosporinic acid nucleus, and the important part is this 6-membered ring. Now that might sound like a tiny chemical change, but it's a huge deal. It makes the whole molecule more stable and way more resistant to a lot of those beta-lactamase enzymes that bacteria use to defend themselves. Okay, so we know they're stable, but how do they actually go in and just dismantle a bacterial threat? Let's get into the mechanism. Cephalosporins are bactericidal. They don't just slow bacteria down, they actively kill them. What they do is they bind to these penicillin binding proteins, or PBPs, inside the bacterial cell wall. This action slams the brakes on a critical step called transpeptidation. Think of it like stopping a bricklayer from adding mortar between the bricks. Without it, the cell wall gets fatally weak and the bacterium just bursts from the pressure. And it's a brilliant design. The core of the molecule stays the same, but chemists can tweak 2 different side chains to create all these different drugs. For anyone in the clinic, just remember this. The R1 side chain decides the antibacterial spectrum, so what it kills. The R2 side chain, that affects the pharmacokinetics, how the drug actually behaves in the body, things like its half-life and how it gets metabolized. All right, let's get to the heart of this explainer and see how this all comes together, the 5 generations. And I want you to think of this less like a list and more like a story of chemical evolution, where each generation gets new and better powers. As you can see right here on the timeline, there's a really clear logical progression. We start out with a heavy focus on gram-positive bugs, and then we just methodically expand our reach to cover more and more gram-negatives, eventually getting to these broad-spectrum powerhouses and even a specialized weapon against the superbug MRSA. Kicking things off with Generation 1, think cefazolin and cephalexin. The mnemonic to lock them in is the PHAs and FAs. Their bread and butter is gram-positive coverage. They're absolutely fantastic for staph and strep. They do have a little bit of gram-negative activity, which you can remember with the mnemonic PCK. That's Proteus, E. coli, and Klebsiella. Clinically, cefazolin is just the king of surgical prophylaxis. Next up, we've got the 2nd generation. Our mnemonic here is the furry fox is drinking tea for cefuroxime, sulfoxetine, and cefotem. They keep that good gram-positive coverage, but they expand their gram-negative reach. The key addition here is hen, Haemophilus, Enterobacter, and Neisseria. But here's the really crucial clinical pearl. Cefoxetine and cefotetin also cover anaerobes, which makes them absolutely vital for treating things like intra-abdominal infections. Now, the 3rd generation marks a huge power shift toward gram-negative bacteria. Just remember, try to tax the TAS for drugs like ceftriaxone and ceftazidime. Ceftriaxone is a total superstar for one massive reason. It crosses the blood-brain barrier. That makes it a first-line therapy for bacterial meningitis. And for those really tough infections, ceftazidime gives us a critical weapon against Pseudomonas. Generation 4 delivers the powerhouse, Cefepime. The mnemonic is super simple. The pime is in its prime. This drug is really the best of both worlds. It masterfully combines the solid gram-positive coverage from the 1st generation with the potent gram-negative activity of the 3rd, including Pseudomonas. It is a true broad-spectrum agent we reserve for serious, often hospital-acquired infections. And finally, the 5th generation, our specialized MRSA warrior, Ceftaroline. Just remember, Roline covers the troll, and that troll is MRSA. This is its whole claim to fame, and the mechanism is just fascinating. It is the only beta-lactam antibiotic that can successfully bind to PBP2A. That's the modified penicillin binding protein that makes MRSA resistant to pretty much every other drug in this class. All right, so we've seen all their power, but for any exam, for any rotation, it is just as important to know their weaknesses. So let's talk about what cephalosporins just can't cover. To remember the major gaps in their coverage, you just need one unforgettable mnemonic: lame. Trust me, this is non-negotiable. You have to know this. So here's the deal. You have got to burn this into your memory. L is for listeria. A is for atypical bacteria like mycoplasma and chlamydia. M stands for MRSA with that one huge exception of our 5th-gen hero, Ceftaroline. And E is for enterococci. I'm telling you, if you see any of these on an exam, a cephalosporin is almost always the wrong answer. It's the trap. Okay, now for the final piece of the puzzle, safety. These are the high-yield side effects and clinical pearls that you absolutely must have on lockdown. First up, the question everybody asks, what about penicillin allergies? Well, there is a 5 to 10% cross-reactivity risk. And the modern way to think about this is, if a patient had a mild rash, you can often use a cephalosporin cautiously. But, and this is a big but, if the patient had true anaphylaxis to penicillin, you avoid them completely. No exceptions. All right, time for a classic board exam question. There is one very specific patient population where using ceftriaxone is a huge no-no, a major contraindication. What is it? The answer is neonates. In newborns, ceftriaxone can actually knock bilirubin off of albumin. This free bilirubin can then cross the infant's undeveloped blood-brain barrier and cause a devastating neurological condition called kernicterus. It can also cause something called biliary sludging. And don't you forget these other key pearls? Cefotatin can cause a really severe disulfiram-like reaction with alcohol. You have to counsel your patients on that. And it can also mess with vitamin K synthesis, which increases the risk of bleeding. Wow, we have covered a massive amount of ground. To bring it all together and really solidify this knowledge, let's look at the ultimate cheat sheet. This is it. This one slide sums up the entire story of the cephalosporins. You can see that progression so clearly. The trade-off between gram-positive and gram-negative coverage, which agents hit Pseudomonas, which ones can get into the central nervous system, and, of course, that unique MRSA coverage from Ceftaroline. Seriously, go ahead and take a screenshot. This is your go-to guide for exams and for your rotations. And there you have it, a complete masterclass on the cephalosporins. From their super stable structure to the specific power of each generation, you now have the framework to totally master these essential drugs. If this helped you out, make sure you subscribe for more high-yield pharmacology. The only question left is,